Our last speaker this morning is Dr. Daniel Kuritzkes. He is the Harriet Ryan Albee Professor of Medicine at Harvard Medical School and Chief of the Division of Infectious Diseases at Brigham's and Women's Hospital in Boston. He received his undergraduate training at Yale and his medical training at Harvard Medical School. He's published extensively, and we mostly know him here in the region as the previous chair of the ACTG. He served as a member of the NIH Office of AIDS Research Advisory Council and was a member of the U.S. Department of Health and Human Services panel on guidelines for ART, just quoted by Dr. Iskandar. He has served on several editorial boards. He's currently still an associate editor for the Journal of Infectious Diseases. He focuses on HIV therapeutics, antiretroviral drug resistance, and HIV eradication. And we are honored that today he will address for us how to best manage HIV resistance. Dr. Kuritzkes.
Thank you very much. It's a pleasure to have a chance to speak with you again. This morning I'll be talking about the art of managing HIV drug resistance. My disclosures haven't changed in the last 2 days. Let's talk about the problem of drug resistance in the treatment of HIV infection. Unlike antimicrobial resistance, where we see the spread in the environment through the use of antibiotics in animal feed and the nosocomial acquisition of drug-resistant microorganisms, emergence of drug resistance in HIV occurs really de novo in each treated person when treatment doesn't go right. And the emergence of resistance is a particular problem with RNA viruses, not limited to HIV, but also seen with influenza, with hepatitis C virus, and that, of course, includes retroviruses. It's important to remember that in an infected individual, the virus population is not homogeneous or clonal. It really represents a quasi-species of very closely related but slightly different individual viral species that we term a quasi-species. The genetically distinct variants within this quasi-species evolve from the initial oligoclonal inoculum, the one or two viruses that succeed in establishing infection following transmission. And these variants are generated by the error-prone RNA-dependent polymerase. Polymerases lack a proofreading function, and so when the wrong base is incorporated during the process of viral replication, there's no mechanism for excising it, and it remains in the viral genome then as a mutation. But resistance has changed over the decades. In the bad old days, the era of monotherapy and dual therapy, and I mean inappropriate dual therapy, not to be confused with the new era of appropriate dual therapy, such as dolutegravir 3-TC or dolutegravir rilpivirine. In the old days, failure to achieve full suppression of HIV replication invariably led to the accumulation of drug resistance mutations, or DRMs. The accumulation of these DRMs led to increasing within-class cross-resistance. So, for example, the more mutations that conferred resistance to AZT, the more likely the virus was to be resistant to stavudine and to abacavir and even to tenofovir. Addition of single agents as new drugs were developed equated to serial monotherapy. So people who started treatment with zidovudine, who then added lamivudine to their regimen, became resistant to both drugs. And then when indinavir was added as a protease inhibitor, resistance promptly emerged to the third agent, and so on, generating multi-drug resistant viruses, or MDR HIV. There was also transmission of drug-resistant virus, including transmission of multi-drug resistant virus, which exacerbated the problem. But this changed over the decades as therapy improved and as the success of antiretroviral therapy and the likelihood of achieving full virologic suppression became greater and greater, given the better potency, greater tolerability, and simplicity of contemporary regimens. And that's illustrated on this slide that I'll spend a moment to take you through. Here, if we just look at all individuals treated in the period from 1999 through 2013, you can see that the number of individuals, and these are data from Switzerland, from Andreas Scherer and colleagues from the Swiss HIV cohort, the number of individuals receiving treatment increased, those who ever had virologic failure to a single or dual nucleoside drug decreased slightly. Those who had had genotyping performed at the time of treatment initiation increased, and those who ever had drug resistance had increased somewhat as well. But if we break this down into the era during which people started therapy, you can see that for those who started therapy before 1999, there was a diminishing number of those individuals, but they are the people who contributed the most in terms of having had drug resistance, shown here in these pink or red circles. But as we look at the most recent period, from 2007 to 2013, you can see that there was a big increase in the number of people starting on therapy, but very few people had any evidence of drug resistance, and hardly anybody had triple-class resistance. So better therapy leads to more complete viral suppression and prevents the emergence of HIV drug resistance. Now, the DHHS guidelines for managing treatment in patients with virologic failure have not changed very much over the years. These are from the 2019 guidelines. I hadn't had a chance since the new guidelines came out in December to update the citation on the slide, but there really aren't any significant changes in how we approach patients with virologic failure. The first steps are to sit down with the patient and understand what is it about the regimen that isn't working for them. You need to evaluate adherence to their therapy, potential for drug-drug interactions, not only among the antiretrovirals, but importantly between the antiretrovirals and other drugs they may be taking for comorbid conditions and other home remedies or allopathic medications that they may be taking. The tolerability of the regimen, which may be driving challenges with adherence, and the potential for previously existing resistance to the regimen. Where accessible, it's then important to perform drug resistance testing in order to assess the activity of the drugs in the regimen and whether any of those drugs might be reused in a subsequent regimen, with the goal of reestablishing virologic suppression with the second or later line of therapy. A new regimen should include at least 2 and preferably 3 fully active agents, although I have to say the data, as I'll show you, really are converging on probably 2 drugs, so long as they're fully active and have an adequate genetic barrier to resistance, being sufficient to reestablish and then maintain virologic suppression. Adding a single new drug to a virologically failing regimen is not recommended because it really recapitulates this prior history of virtual monotherapy, and if the wrong single drug is added to a failing regimen, the likely outcome is incomplete viral suppression and loss of that new drug. That said, for some very highly treatment-experienced patients with extensive drug resistance, maximal virologic suppression may not be possible. But in that case, persisting with some form of therapy that's designed to minimize toxicity and preserve CD4 cell counts and may still delay clinical progression and is an important goal to achieve. I touched on the issue of pre-existing drug resistance, and we know from work done through the AIDS Clinical Trials Group now more than a decade ago that pre-existing drug resistance, in this situation most likely transmitted drug resistance, has a significant negative impact on the success of the regimen if the transmitted resistance is resistance to the non-nucleoside RT inhibitors and if an efavirenz or an nevirapine-based regimen is used. So in this retrospective analysis, we made use of baseline samples from ACTG 5095, which studied efavirenz in combination with various nucleoside RT inhibitors, and the study was initiated in an era before pre-treatment and drug resistance testing was standard in the United States, and so patients who enrolled in this study were not pre-screened for the presence of resistance. Then we went back to the baseline samples, did viral genotyping, and identified those who had resistance to efavirenz or the other NNRTIs, and showed that those participants were 2.5 times more likely to develop virologic failure over the course of the study compared to those who had wild-type virus. And what you see is that having resistance did not always lead to failure. A small number of people managed to remain virologically suppressed, and not having resistance was certainly no guarantee of success, because all of the issues around adherence and tolerability still played an important role. So resistance is an important determinant of treatment success, but it's not the sole determinant of treatment success. Now, this study was done with standard Sanger sequencing, and if you apply more sensitive techniques to identify minority variants, and Denise talked about the importance of minority variants contributing to resistance to the BNAbs, well, they're certainly important as well in determining resistance to standard small molecule forms of therapy. And here, John Lee in my group did a pooled analysis of data from 10 different studies looking at patient-level data where individuals in the studies, different investigators had gone back using a variety of techniques, including next-generation sequencing and allele-specific PCR, to very sensitively detect the presence of resistance to the non-nucleoside RT inhibitors, and showed that, again, there was about a 2.5 times greater risk of virologic failure if you had pre-existing minority variants, which were undetectable by standard viral genotyping compared to those who did not. But again, you'll see that more than half of the participants who did have minority variants managed to be successfully suppressed. So in this situation, we can say that very sensitive techniques for detecting minority variants may have high sensitivity but low specificity for, and therefore not terribly good predictive value for who might fail on a particular regimen. Now, the importance of, I've focused up until now on the importance of pre-existing resistance to the non-nucleoside RT inhibitors. Resistance to the nucleoside RT inhibitors has been shown to have much less of an impact on contemporary regimens, including NNRTI-based and boosted protease inhibitor-based regimens. And these data are from Anna Maria Giretti in London, and show you that here the solid lines are those who had no resistance, and the dotted lines are people who had resistance. The difference between the dotted and solid lines are really not statistically significant because it appears that having transmitted resistance numerically made you slightly more likely to succeed, but that's not really a significant finding here. And what you'll notice as well is that the NNRTI regimens actually did better than the boosted PI regimens, but this is not a randomized study. This is a retrospective cohort analysis. But these results have been challenged by the findings in the ANRS 12249 study, the TASP trial, where looking at comparing the absence of any previously existing drug resistance to resistance only to the non-nucleoside RT inhibitors, or presence of resistance to both the non-nukes and the nucleoside RT inhibitors, they were unable to see any difference if you had only NNRTI transmitted resistance, but there was a difference if you had resistance to both classes. And recently, in a 1,000-participant cohort in KwaZulu-Natal, Vince Marconi, John Lee, and I have been able to show very similar results and we'll be presenting those data at CROI, showing that there is about a 2.5 times greater likelihood of failure if you have resistance to both NNRTIs, in that case efavirenz, and either 3TC or tenofovir. Well, the data I showed you from Anna Marie and our previous data were all based on non-nucleoside RT inhibitor failure and the use of boosted protease inhibitors in second-line regimens. What about the use of integrase inhibitors? Are they as reliable and as potent as boosted PIs for use in second line? Because we know that the second line study, EARNEST and SELECT, all showed persistent activity of some of the nucleosides despite the presence of resistance, although it's important to note that there were very few participants in those first 3 trials who had a K65R mutation that confers resistance to tenofovir, now the more common component of the viral backbone. And success of the second-line regimens was largely based on a boosted PI regimen. And so that the question then is, can a drug like dolutegravir or potentially bictegravir take the place of a boosted PI in a second-line regimen if there is a pre-existing nucleoside resistance? And that's the subject of the Dawning study, which compared dolutegravir with 2 nucleoside RT inhibitors to boosted lopinavir with 2 nucleoside RT inhibitors in participants who were failing on a 2-nuc plus NNRTI first-line regimen. They had to have been receiving that regimen for at least 6 months, have virus loads of above 400 copies on 2 occasions, and no primary resistance to PIs or to integrase inhibitors. So one of the key aspects of this study, which although it was conducted in resource-limited settings, is that it introduced and made available a technology that is not necessarily widely available in routine clinical practice. And the primary endpoint was achieving viral suppression to less than 50 copies per mil at week 48 using the FDA snapshot analysis. And what the study showed was that dolutegravir outperformed boosted lopinavir by a wide margin, not only achieving non-inferiority, but actually demonstrating superiority, as you can see here in this analysis. And that was also true in the per protocol analysis shown in the hatched bars here. Now, one of the issues that arises is although there was a superiority of dolutegravir, it's not clear that that's due to greater virologic activity so much as better tolerability of dolutegravir as compared to the ritonavir-boosted lopinavir regimen. A number of sub-analyses were subsequently presented asking how did resistance to different components of the regimen affect the outcome in the study, and that really had little impact. So in this slide, what you're seeing is the impact of resistance to lamivudine or emtricitabine with a mutation at RT position 184, and here the blue bars are the dolutegravir arm, and the orange bars are the boosted lopinavir arm. And you can see the numbers are really pretty similar across the board for the study overall, whether you did or did not have a 184V mutation, and whether you did or did not use either 3TC or FTC in the context of a 184 mutation. In each setting, dolutegravir still outperformed lopinavir, and the level of the rate of success didn't change. The data were also analyzed with respect to the presence of the K65R mutation, but here there are a couple of shortcomings in the data, certainly not the fault of the investigators, but just the context in which the study was performed. There were only 15 participants who had a K65R mutation who also received tenofovir, and because of the study design, they had to receive at least 1 active nucleoside RT inhibitor. So if they had a 65R, which confers resistance to tenofovir and lamivudine or emtricitabine, they must have been also receiving zidovudine in order to have an active drug. So we don't really have data that address the question of what happens if you use tenofovir in the setting of a 65R mutation together with dolutegravir, and that's extremely important given the rollout that is now occurring. Well, focusing now on resistance to the integrase inhibitors, you can see in this chart taken from the Stanford Drug Resistance Database that there's extensive cross-resistance among these drugs. Some of the mutations have a much greater impact on the first generation of integrase inhibitors, raltegravir and elvitegravir, and the 148 mutation, when coupled with other mutations, having a bigger impact on dolutegravir and bictegravir. So the Viking study looked at different doses of dolutegravir in participants who had previously failed on a raltegravir-containing regimen and had accumulated different numbers and types of raltegravir resistance mutations. And here what you see is the fold resistance to dolutegravir increases with increasing numbers of mutations, particularly when the 148 mutation is included with other mutations. And this study also found that when dolutegravir was administered twice daily, there was a better success rate than in the individuals who received dolutegravir once daily, hence the recommendation to use dolutegravir twice a day in the setting of prior integrase inhibitor resistance. That is a somewhat soft result, however, because it also turned out that the highest levels of resistance were in the once daily arm, so we don't really have parity in terms of the level of dolutegravir resistance, and you obviously couldn't randomize people to have different levels of resistance in the study. Well, let's turn now to some of the newer drugs that are available or just becoming available for the treatment of patients with highly resistant virus. And the first of these is a monoclonal antibody called ibilizumab. Ibilizumab was initially a monoclonal antibody isolated in mice. It targets the second domain in the CD4 molecule, and the antibody was then genetically re-engineered to be humanized so that it would be less likely to generate antibodies when administered to people, and it inhibits post-binding entry of the virus. So as you can see here, the heavy and light chain of the antibody bind to this second domain of CD4, so they leave available the tip of the CD4 molecule to which GP120 binds. So the virus can bind to CD4, but then it can't undergo the necessary rearrangements to engage the co-receptor and proceed with viral fusion with the cell membrane. Years ago, we did the phase 1, actually 15 years ago, we did the phase 1 study of ibilizumab, single ascending dose study, and you can see that a single infusion led to up to about a 1.4 or 1.3 log reduction in plasma HIV RNA that took about 14 days to achieve. So slow virologic decline, but moderately potent activity. There were a series of misadventures with this molecule in terms of its clinical development, but finally a phase 3 study using the novel salvage therapy trial design that had been worked out through the Forum for HIV Collaborative Research in partnership with the FDA, with the community, and with investigators was done that led to the approval of this drug. And so this is a really unique type of phase 3 study. This study looked at participants who had limited treatment options, enrolled them into the trial, and then followed them for 7 days doing absolutely nothing. And this was just to establish the baseline variability in virus load. Then all of the participants got a single loading dose of ibilizumab, and the primary endpoint was 14 days later. Not at 48 weeks, not at 96 weeks, and no comparison arm, because the comparison is where was your virus load at day 14 compared to where it was at day 7, and was the change from day 7 to 14 different than the change from 0 to 7, which was should be essentially zero change. After day 14, participants could optimize their background regimens if they had any other drugs that might be added to the regimen, and then they were followed for additional time for safety of the ibilizumab, and during which they were receiving 800 milligram IV doses every 2 weeks. What you can see from the table here is that only a single individual in the control period had a decline in virus load of more of half a log or greater, whereas during the monotherapy period, 33 of the participants had such a decrease. 24 of them achieved a 1 log decrease, with the mean change in virus load being just over 1 log compared to no change during the control period, and this was highly significant. But you note this phase 3 study had only 40 participants in it, so this is really a novel way of doing business, and the intent is to minimize the number of people who are exposed to potentially partially active regimens. But if we look at more classic criteria for success, you'll see that in the overall intention to treat population, only about half of the participants achieved fully undetectable virus loads. That seemed to depend on the baseline CD4 count, much less success in patients with more advanced disease compared to those with less advanced disease. And the improvement in CD4 count likewise depended on where you started, with just about a 70-cell increase overall, but closer to a 100-cell increase in those who entered with more than 50 cells to begin with. Resistance does emerge to imbelizumab, however, and these are data developed by Toma and colleagues from Virologic using samples obtained in the phase 1b trial. And you'll notice this odd change in the shape of the inhibition curve. We don't see a shift to the right of the IC50, but a flattening of the curve, which is classic for non-competitive inhibitors, as we saw with resistance to the CCR5 antagonist Maraviroc. And these mutations occur in the interface where the antibody binds to the you might be surprised that there are resistance mutations that occur because the antibody doesn't bind the virus, it binds CD4, but the mutations occur at the interface where the virus interacts with CD4. Well, let me spend the last couple of minutes talking about another new agent, fostemsavir, which is also an entry inhibitor. Fostemsavir is a prodrug of temsavir. You can see temsavir here, the active drug, and this is the phosphorylated version. This is a first-in-class attachment inhibitor that binds to GP120, therefore prevents viral attachment, is active against viruses regardless of which co-receptor they use, and is synergistic or additive together with other anti-HIV drugs. For this phase 3 trial, a somewhat different design was used. Here, 2 studies were done in parallel. A randomized study where participants who had at least one remaining available drug were randomized 3-to-1 to either get placebo or fostemsavir for an 8-day period, with the primary endpoint being the change in virus load between day 1 and day 8. And then everybody received open-label drug and optimized their background regimen. In addition, for those who had no remaining options, in a form of a compassionate use trial rolled into the phase 3 trial, the individuals were allowed to simply receive fostemsavir and do what they could with their background regimen. You see that this was a very highly treatment-experienced group. Even 70% in the non-randomized cohort had already tried enfuvirtide. And if you look at the number of agents that were available, you can see that nearly 80% of those in the non-randomized cohort had no other drugs available, whereas about half of the participants in the randomized group had 1 or 2 drugs available to add to the fostemsavir. And the clinical endpoint, the primary endpoint showed a 0.8 log reduction at day 8 compared to a 0.17 log reduction in the placebo group. That was statistically significant. And then if you look at the proportion who actually achieved full virologic suppression, the results are not all that encouraging. About 57% in the randomized cohort got to less than 50 copies. About 80% achieved suppression to less than 200 copies. But in the open label group, the compassionate use group, that number was closer to 40% achieving full suppression. Interestingly, there was a continuous increase in CD4 counts over time in the randomized group, plateau in the CD4 counts in the non-randomized group, and the significance of that is still being explored. So let me finish by summarizing and saying that the goal of treatment for patients with complex antiretroviral treatment histories is full virologic suppression, as it is for initial therapy. New drugs with novel mechanisms of action increase our options for constructing treatment regimens that contain 2 or more active drugs. But even when full virologic suppression can't be achieved, a regimen should still be administered and designed to minimize toxicity, preserve CD4 counts, and hopefully delay clinical progression while waiting for the next new drug to come along. And with that, let me thank you for your attention and hope you enjoy the remainder of the conference.